You're listening to Medscape's In Discussion series on Idiopathic Pulmonary Fibrosis, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Jeff Swigris, Professor of Medicine in the Interstitial Lung Disease Program at National Jewish Health in Denver, Colorado. Dr. Swigris directs research centered on how patients live with and experience interstitial lung diseases, how to best assess that experience, and how quality of life may be improved for patients suffering from interstitial lung disease. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Welcome to Medscape in Discussion on the topic of idiopathic pulmonary fibrosis, or IPF. I'm Dr. Jeff Swigris, and today we'll be discussing the long-term follow-up of patients with IPF and how remote monitoring may play a role. How and how often should we follow patients? Can we or should we do some of it remotely? And if so, what might that look like? With me to dig into these questions is Dr. Marlies Wijsenbeek, a pulmonary physician at the Erasmus MC University Medical Center in Rotterdam and a world-class expert in IPF. She is also chair of the Erasmus MC Multidisciplinary ILD, or Interstitial Lung Disease Center. Her research interests include patient-centered outcome measures in interstitial lung disease, e-health, and new therapies in IPF and sarcoidosis. She's the perfect guest for today's topic, and I am so happy to have you here, Marlies. Welcome.
Thank you. I'm very happy to be here and excited to talk about this topic.
So, Marlies, tell us how you got interested in interstitial lung disease and IPF.
In 2007, I started creating an ILD center here because that was the time that we really had not much to offer people with IPF and with other forms of progressive fibrosis. It was mostly supportive care. So there was a major unmet need for these patients, and there was also a major need for better therapies. And the field has changed in the past decade. We have antifibrotic drugs which slow down disease decline, improve outcomes for patients, but we should remember it still remains a deadly disease, and support is still very much needed for these patients. So to your question, I think it is to help people to live as long and as well as possible, and doing this together with a team and also doing research to improve the field.
Well, let's dig in. Let's talk about how we follow these patients and try and help them live as long as possible and as well as possible. Okay, Marlies, so you've just made the diagnosis of idiopathic pulmonary fibrosis on a typical patient. This is a 67-year-old gentleman, former 30-pack year smoker. He's had 12 to 18 months of this insidious shortness of breath when he exerts. You diagnose IPF. How are you going to follow him over time? What's your approach to testing? What do you do and why do you do it?
Yeah, I think this is something that we all see in our practice. In our country, we agreed in the national guideline to see these patients every 3 to 4 months, including pulmonary function tests, which include an FVC and a DLCO at the minimum. And furthermore, we have to think if patients are just starting on medication, that it also involves labs. And then normally our specialist nurses will call after about 4 weeks how it's going with the medication and how the tolerance is. HRCTs and 6-minute walks we do mostly on indication. And furthermore, nowadays, we also offer remote monitoring to patients.
That's great. So just to clarify for listeners out there, so FVC, forced vital capacity or lung capacity, DLCO or diffusing capacity of the lung, HRCT is a high-resolution CT scan. How frequently will you do scans on patients, Marlies? Do you do that as a routine at certain intervals, or do you let the clinical scenario dictate? What's your approach there?
In patients with IPF, I usually let the clinical scenario dictate. If there's any unexpected change in the situation, and I want, for instance, to exclude a pulmonary embolism, there is a very rapid progression where I have no explanation, I would make an HRCT. if there is suspicion of a malignancy, I would make an HRCT, but we don't standardly do HRCTs, but in practice it ends up that each patient usually gets a CT about every 1 to 2 years because there's often things happening.
Right. Unfortunately. Right.
Yeah.
You mentioned remote monitoring. So take us through that. I know that you've built a remote monitoring program there in the Netherlands, and I would love to hear more about it. How do you actually do it? How is it operationalized, and so forth?
Yeah, this already started in 2015 when we saw how much patients struggled to come to the hospital. They had to take oxygen. Their family had to take days off from work to bring them. And we thought maybe this can be done easier, especially if everything is stable. So we made together with patients a system that includes home spirometry. So the patients have a small device that measures lung function at home, which sends it via Bluetooth automatically to the hospital. And furthermore, they keep track of their symptoms, of their side effects, of their health-related quality of life. And they have a sort of chat box where they can send messages to the nurse, and we can do video consultations also if we want. And especially the medication coach, the patients like a lot, because if they rate side effects on a certain level, that gives a pop-up on how they could deal with that. And it asks them afterwards, is this enough or not? And if not, the nurses get a message.
So patients will use their iPad or their smart device, whatever it is, a cell phone. And how frequently are you asking them to do spirometry?
In the beginning, we started because we were learning with daily, but that turns out to be too much. So the majority of patients do it about weekly, but some patients also still keep doing it daily because they like it, and others do it monthly. But the majority of patients do it weekly. So outside of research setting, we leave it a bit up to the patients, but we advise 3 blows once a week. And then it selects the best blow, like in clinic.
Across the world, the pandemic has made us think about remote monitoring, and here in the States, it's definitely making its way into our care. I wonder if you could share with us, so you have patients doing this at home and they're filling out questionnaires on their smart devices, they're doing spirometry. How frequently are you looking at their data?
Yeah, that's a very good question, because at the moment we are only looking at the data if there are problems. So if they send us a message or call us up that they have a problem, we look at the data, or if we have a scheduled remote visit. So then I look back on how the data are in the past month. And I rather have several measurements because we see some variance at home. So if you have several, you have a nice trend. You don't have a technician sitting there and coaching the patient. You have a bit more variability. In studies, we did alarms, but that gives quite a lot of work because then you have to filter out all the measurement variations or the grandchild that did a blow on the machine or things like that. So nowadays, I only look when they call for problems or when I have a consultation with them. And obviously, they don't do the questionnaires every week. They do that on bigger intervals.
Right. So then if a patient is at home and they seem to be doing okay, they're tolerating their medication, you might have a follow-up at 4 months. And then do you try and bring a patient into your clinic then on a routine, or they're just monitored at home and you're happy with that?
I think COVID made a big shift here. In the COVID times, we started up about a little bit over 300 patients countrywide, and we saw that we replaced about 50% of in-hospital visits by remote care, obviously forced by COVID. We see that goes down a bit now again, but we're going to start an implementation program here to see if you can replace safely and also with patient and doctor satisfaction half of the visits by remote monitoring. Because in the end, we don't want patients to travel to us and have a lot of hurdles if they're stable and if they're well. But if they need us, they should come even earlier. So that is the balance you would like to find, that you create space in your clinics for patients that need you at that moment, while the patients that are stable don't need to travel to you.
Right. I think that's a great setup. let's shift gears just a little bit and stick with our theme of longitudinal surveillance. So there are a handful of comorbid or related conditions in our patients with idiopathic pulmonary fibrosis that we all think about. And I don't think there's consensus on when and how, or even whether we should look for these things. And so what I'm talking about are gastroesophageal reflux, GERD, obstructive sleep apnea, and pulmonary hypertension in particular. So these three comorbid conditions or related conditions to idiopathic pulmonary fibrosis have a bunch of interesting data behind them on whether they may be in some way related to disease progression. We know that each of them is relatively common in patients with idiopathic pulmonary fibrosis. So give us your thoughts on, do you check for them? How do you check for them? How frequently, and the like?
Yeah, I think it starts already at the first consultation. So we ask, for instance, for gastroesophageal reflux. We don't do all kinds of investigations. We're pretty pragmatic in that. Except for the patients that go for transplant, they have a more rigorous workup. But in the average 67-year-old male you just talked about, we'll just ask about reflux. If there's reflux, I would treat. If there's no signs and symptoms of reflux not reported, I will not treat. And that's, I think, also according to the guideline, not to treat reflux for the sake of the pulmonary fibrosis. For obstructive sleep apnea, we also just ask about it or use questionnaires, because I think it is important to detect it. It will improve quality of life for patients if you treat this. Whether that also will make them live longer on the long term, we don't know yet. But I think also improving quality of life is important. As for pulmonary hypertension, that's tricky. I think it's good to realize in which setting you are. In the Netherlands, we don't have approved drugs for the treatment of ILD-related pulmonary hypertension. We do screen for it if we have an unexplained decrease in the LCO, especially, or in lung function. We also screen for it in case of transplants, but often we don't have to offer the patients much more than conservative and supportive measures for that. So it doesn't have that much consequences. So we always think of the consequences on screening. And if we screen, we usually screen with ultrasound, except for the transplant patients.
So let me just clarify. Marlies brought up a great point about gastroesophageal reflux. There was a time where many people thought, boy, gastroesophageal reflux all the way up to the larynx and then with microaspiration could well be one thing that causes progression of IPF. And with those very weak observational and retrospective data, many of us said, well, we're going to put all of our patients on anti-acid therapy. Any patient with IPF should automatically be on a proton pump inhibitor with the intent to slow disease progression, thinking that, well, if we decrease the acid content of the reflux, even if stuff is still getting down into the lungs through the trachea via microaspiration, it's probably better that it's not acidic. The most recent treatment guidelines that just came out in 2022 suggest that that is not appropriate. So using a proton pump inhibitor with the intent to slow disease progression in idiopathic pulmonary fibrosis is no longer warranted and is not considered standard of care anymore. Marlies, you mentioned the 6-minute walk test. And, I wrangle with this all the time because it's seemingly a simple test. You tell a patient, walk as far or as fast as you can in 6 minutes. Don't run or jog. If you need to slow down, slow down. If you need to stop and rest, stop and rest. We're going to keep the clock going, right? Pretty simple. But it's just become so convoluted whether we measure oxygen saturation or not and what we do with those data. At your center, are you measuring peripheral oxygen saturation during a 6-minute walk test? And do you have stopping rules?
Yes, we do measure it. We have a sensor that goes on the forehead. So that sort of reliably seems to measure it. And I mostly do these tests to see if they desaturate on exercise. So I don't care if it is, completely reliable with the number of meters. And you don't use that except in patients that are in trials or go for transplants. But for the other ones, I think the important thing is, do they desaturate on exercise? And could you give ambulatory oxygen for that to improve their breathlessness and probably their exercise tolerance, as has been shown in a very nice study from a group in the UK that showed patients that desaturated on exercise below a saturation of 88% actually benefited from ambulatory oxygen use. So that is the approach I take to it.
How about in terms of remote monitoring oxygen saturation or oxygen needs? Do you incorporate that into your remote monitoring, and if so, how?
Yeah, we started doing that actually during COVID because it became so relevant then when patients actually had COVID. But I think we have to acknowledge that we don't have very good data on which is the best pulse oximeter and how to do it. And you have to at least explain to your patients that you need a good signal, warm hands, and see a pulse so that you get reliable data. Otherwise, they call you up that the measure says 48%. Probably it's not measuring there. And the new home spirometry has a field under your thumb where you automatically also get the oxygen saturation. It is pretty useful. Some weeks ago, I had a guy who called me up. I'm feeling more short of breath. At the last 3 days, I did my PFTs and I see that my FVC goes down. And I also see that my oxygen sats go from normally 94 at rest now to 91 at rest. So that was a moment that I got worried about him. I had him come into the clinic and he turned out to have a pneumonia. So, these are things that actually are quite helpful on a distance to monitor and detect.
Right. Remote monitoring has that capability for us to be able to detect abnormalities, to detect decline before a patient is waiting 3 or 4 months to come back in and see us. So I think it makes a lot of sense, and hopefully it leads to improved care. Well, we are short on time, so let's wrap up with a question. What do you want physicians or practitioners who are treating patients with IPF to consider doing differently in today's day and age? Is there something we should change about how we monitor our patients over time?
Yeah, I think in the whole trajectory, we can still improve things. It already starts at diagnosis. You have to be timely in talking about initiating treatment, about that this is a progressive disease, and about referring to a transplant center. Also, I think you have to be supportive, so they should be able to always reach you, whether that is remote or in real time according to your setting. You have to talk about vaccination, symptom relief, measures to improve their quality of life, exercise. And I think also if end of life is approaching, be honest. If in your head you think, I'm not sure if I will see these patients the next year, then it's time to talk about advanced care planning, because you don't want these patients to end up with a junior doctor in the emergency room deciding that they go on mechanical ventilation when they have end-stage lung disease and die on an ICU instead of with their family at home. So I think those are all fields where we can still improve the care for patients.
Absolutely. Absolutely. So, Marlies, thank you so much for being with us today. This information is incredibly helpful. And I think you've highlighted the direction in which our field hopefully is going, and that is to unburden our patients and not make them travel to our centers all the time, that we can get reliable data from remote monitoring at that 3 to 4 month interval that we all know is so important in following these patients over time. Thanks for being here. Thank you for sharing your experience with us.
Thank you.
And to the audience, thank you for listening to this conversation on idiopathic pulmonary fibrosis with our guest, Dr. Marlies Wijsenbeek. There's much more ahead in the coming episodes, so please be sure to check us out on the Medscape mobile app and share, save, and subscribe if you enjoyed this episode. I'm Dr. Jeff Swigris for Medscape in Discussion.
Thanks for listening to Medscape's In Discussion Idiopathic Pulmonary Fibrosis podcast series with our host, Dr. Jeff Swigris. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on idiopathic pulmonary fibrosis.